Hi, this is Miss Gray beginning the lecture on assessment. Assessment is the first part of the nursing process. The nursing process is comprised of 5 elements: assessment, nursing diagnosis, planning, implementation, and evaluation. Um, the acronym for these 5 elements is called ADPI. ADPI. ADPI: assessment, nursing diagnosis, planning, implementation, and evaluation. Now this lecture, and on Tuesday, we're going to focus on just these elements. What is assessment? It's the key, it's the most important thing that you can learn to do as a nurse and learn to do well. Because if you are not assessing thoroughly and completely, you are going to miss important information and cues that can guide you in the care of your patient. A good nurse is a thinking nurse, and a good nurse is thinking all the time. You have a legal, ethical accountability, which we've already learned about through the ANA, through the State Board of Nursing standards, that you're held accountable to, so it's very important that you do it. Now, assessment involves collecting data, and once you collect it, you've got to be organized, you've got to remember to check things out, and you've got to document what it is you do. So an example here is in our next slide. If I get to the next slide here. To get to my next slide, and I will get to the next slide. So the next slide here is the nursing process and action. So you're going to notice here that Nurse Medina is doing a physical. She's collecting data. From that data, she's going to determine if there's a problem that she can solve by good nursing care. And then she's going to have a plan. And then she's going to have a set of actions. Implementation is a set of actions that are needed to actualize the plan. And then she's going to evaluate and see if her plan worked. So the key here is the nursing process is dynamic. It's dynamic, not and cyclical. It's dynamic, meaning it's always going on. It's always going on. Let me erase that. Miss Gray is trying to write. It's a dynamic process, and it's cyclical. So our patients we're always assessing, no matter what. As long as the patient is in our care, we are always assessing them. So assessment and the nursing process is dynamic. It's continuous. It's dynamic and continuous. As long as the patient is in our care, it's dynamic and continuous. That's really important to remember. And then we have to remember, so we've talked about the nursing process. It has 5 elements. And so the characteristics of the nursing process, again, are that it's cyclic and dynamic, not static. Static meaning that it stays the same and doesn't change. It's client-centered. Our purpose is to care for our residents or our patients, providing them with good care. We're providing them with care, and we're looking to see if there are any problems that we need to solve. We have to make good decisions. We have to be interpersonal and collaborative with the other members of the interdisciplinary team. Our nursing process has universal applicability. It means that no matter what area of nursing you're working in, whether it's OB or the ER or a nursing home, we're still going to process through the same nursing process. The care method of thinking as a nurse is the same regardless of your specialty. or where you work. The expectations set by the government and by our professional organizations, the standards of care for nurses uh, expects you to utilize and perform your nursing actions based on this nursing process. So these are, and of course it involves critical thinking skills. Now, again, so focusing on assessment, assessment, as I told you, involves these four related activities. First, we have to collect the data: vital signs, temperatures, looking at skin, looking at wounds, smelling. There might be odors that pick up from a wound. So we're collecting data, and then once we collect it, we have to organize it. So when you do a full assessment, you might say, okay, how is their neural status? And then you go to the heart. What was their cardiac status? And what was their respiratory status? And you keep moving down. How is their stomach, diet? How's their bladder function? So you collect data and you organize it. Typically, we organize our information by systems. And when we look at the Gordon's, Gordon's is the format by in MATC by which we teach the nursing process. So it has the Gordon's functional health patterns. Again, the functional health patterns kind of emulate a head-to-toe assessment. So it's just a method of collecting, an organized method of collecting data. And then once we collect the data, we have to validate and check the data. We want to, that's why if we have a nursing assistant getting our vitals for us and those vitals are elevated, we want to double check, because other healthcare providers make their decisions on the data that we write. We don't want a physician writing an antihypertensive medication for a blood pressure that's really normal because we didn't double check. So we don't want to document a blood pressure of 180 over 100 if we haven't double checked it, because the physician might determine his medical decision making on what you documented. The physical therapist might say, if that patient's blood pressure is 180 over 100, maybe I won't have them go through physical therapy today. So you see, everything that you do has a accountability element to it, because other people of the team, your patient's care, and your patient's care are derived out of the data or impacted by the data that you collect and that you document. So accuracy is important. Not anything will do when it comes to nursing. We have to be practitioners of excellence. You have to want excellence. And if it's just really important to become detailed and excellent. So again, we collect, we organize, we validate, and we must document. Because remember, as I told you, if you didn't document it, if it's not done, if it's not documented, it's not done. So we must document everything that we do. So, having looked at the fact that we have to collect, organize, validate, and document, then we have to, I want you to understand there are 4 types of assessments. Now, if you recall, when we were looking at our first couple units, we talked about the areas in which nurses might work. You might work in acute care. You might work in a nursing home. You might work in a clinic. So where you work might determine the, this is not working, might determine the level of assessment or the kind of assessment that you are going to do. So the key is, whenever you're seeing a patient for the first time, it's going to be, because in general, your first assessment is your initial assessment. When you have a patient that's And then after your first, and that can happen all in one day. So then after your first assessment, and instead of patients coming in with abdominal pain, you determine the abdominal pain on the first assessment. Then you go back and check on them. Your problem assessment, you might give them something for pain, but you might reassess them for the same problem. So as an assessment, you can do an initial assessment, and then you're going to go back and reassess, because your reassessment is going to help you determine, again, anyway, if your plan worked. So you might go do an initial head-to-toe assessment. Your first assessment might be a complete head-to-toe assessment. And then you might go back and reassess just looking at one particular area. You could have an emergency assessment if a patient has a changing condition, like chest pain, or if they look like they're having signs of a stroke. That could then be an emergency assessment. Then you might have a time-lapse assessment where your patient's coming in for various tests. So there are various types of assessment, and that depends again on where you work and the kind of work that you're going to do. So again, your initial perform with a specific time. Your problem focus assessments are ongoing, integrated in your care. And you might have an emergency assessment performed during a crisis, and your time lapse can occur over several months. Now, when you're collecting data, you're gathering information about the patient's health status. You're looking at the past medical history, and you're looking at the current problem. So you might, for example, have a patient who is a diabetic, but they're coming in for abdominal pain. It's going to be important for you to know their diabetic status. How is it managed? What are their blood sugars? Are they getting treated with insulin? Are they being medically managed with, or orally medicated with pills? Or are they being managed by diet? You'll need to know what their blood sugar levels are. And then you're going to have to still address their abdominal pain, because how long has the abdominal pain been going on? Is it aggravated by any kinds of foods? You are not there. That patient might be having abdominal pain and throwing up, but did they already take their insulin? So what are you going that's going to be dropping their blood sugar? So you have to think about the patient, you have to think about multiple things at a time when you're a nurse. That's why learning to hear, learning to process information is so important, and gaining a confidence about what you hear and what you hear. You have to begin to have confidence in what you are hearing from the patient, because you're not always going to have someone to check it against other than the patient. So gaining confidence, being clear, asking questions is always going to help you. Gathering data is an organized process, and again, it's continuous. You're always collecting data. Your assessment's always going to include your past history and your current problem, as I said. And you're going to collect data that is both subjective and objective. And then you're going to, which is subjective data being what you can't measure, but objective data, things you can measure. And your data is also going to come from the primary source, which is the patient. Your primary source is the patient themselves. And your secondary source is going to be family or medical records, something other than the patient. Your secondary sources are other than the patient. And then we have then we're looking at our different kinds of data. We're looking at, again, looking at collecting our data. 1 minute. primary and secondary sources, and the kinds of data. So subjective data. Subjective data are your symptoms that you cannot measure. Subjective data is not measurable. It's whatever the patient says it is. For example, if a patient says that they are nauseated, we cannot measure nausea. It's what the patient says it is. Another common subjective complaint is pain. Now, we typically will ask the patient to rate their pain 0 to 10. Can they give us a rating of 0 to 10? 0 being the least and 10 being the most. Though we're asking them to rate the pain, it still is subjective data because we can't actually measure it. What might be a 5 pain for me might be a level 10 scale for somebody else. So it's whatever the patient says it is. We ask the patient to rate pain so that we can have an idea of what to implement, what to give them, how to address it, but it is still subjective data because I cannot actually accurately or truly measure it with any kind of instrumentation. So subjective data is not measurable. It's apparent only to the person that's affected. It can be described by that patient. I can't tell you how you're feeling, right? You can't tell someone how they're feeling. And it includes sensations, feelings, values, beliefs, attitudes, and personal health status and life situations. So a common subjective-ish problem is a headache. Your headache, a headache, pain, nausea. Again, subjective data cannot be measured. Your next type of data is objective data. They have overt signs. It's detectable by the observer. You can see it. It can be measured or tested against an accepted standard, like blood pressures. It can be seen, heard, felt, or smelled, and it's obtained through observation or physical examination. And you'll see here, objective, this patient is sneezing. We can say the frequency, how frequently is she sneezing? Is there drainage with the sneezing? Is there a fever with these symptoms? So two things, we can note that she's sneezing, note if there's drainage, and determine is there another course of action? Do I need, from watching her sneeze, is there more information that I need? Does she have a fever? What do you begin to think about what you see? What actions do you think you need to take as a nurse? Another type of objective data could be a patient having an emesis. As the nurse, then, you're going to want to note the color of the emesis. If you can you measure the emesis? Did he do it in a basin or something you can measure? You might think, are there any associated complaints with this emesis? Is there pain? Is there nausea? Did the patient eat something that caused them to have the emesis? So again, the emesis itself is objective data that you can measure. It has some measurable qualities, but you as the nurse also, when you measure something, you're again thinking and developing other questions about that data to determine, do you need to do something else? Again, this demonstrates the dynamic process that we're in related to nursing. And the nursing process is dynamic, it's always going on. So whenever we see something, we should be thinking something else. A good nurse is a thinking nurse, and therefore you're thinking all the time. So we have here a bruise. And again, bruise is measurable. We can measure the size of the bruise. We can measure the size of the bruise. We can look at That's an older bruise here. It's lighter, but we can see how wide it might be. We can see look at the tenderness. Is it warm? Is it intact? So we have a bruise here, and there are other observations that we can make about that bruise. Again, color, size, tenderness. Is the patient able to move the limb? We see something, and then we want to think about other questions to help us better help the patient and do a good and complete assessment. We have here again a cut. You're going to look at the cut and you're going to determine, what is the length of the cut? Is there drainage from the cut? What color is the drainage? Is it bloody? Is it serous? Is there odor? What is the consistency? Is it dried? What is the length and depth of the wound? So you look at something, you want to get more information about it. Again, other objective data can come from the medical records or from vital signs. So other objective data can be blood pressures, anything measurable, blood pressures, temperatures, lab results, x-rays, CT scans, and other medical records can comprise our other sources of data. Again, to review, when we have the primary data source is the client, and the secondary source is any other sources of data, which you, again, might be any of these. Methods of data collection. Again, this is a review. Kind of integrates the concept of communication. When we're looking at these, this is all part of communication. As part of communication is our observation skills. So you can gather data by looking, by observing, smelling, touching. So you use your 5 senses to help gather information about your patient. And then you want to interview. You're interviewing. We talked about communication in the last unit. Interviewing involves talking to your patient, getting good information, using open-ended questions. Open-ended questions help you gather more data. When your patient is talking to you, then you're going to get better data. So you want to have open-ended questions. And then you want to be open when you're talking, establish a good purpose, control the interview, and make sure that you're gathering information in a timely manner as well. And part of building that rapport with your patient and getting the information means building a rapport, making sure that that the patient's giving you good information, but you really do want to control the interview. Asking open-ended questions. Your closed-ended questions are restrictive and factual. You're going to always get more information when you're asking open-ended questions. Again, this is a review from the communication unit. So you should be seeing a transfer of information and themes one unit to the next. Also, you want to look at your interview setting. You want to make sure that you're going to get better information when your patient is comfortable. So timing. You want to think about when the timing of your interview, the timing of your care, the timing of your assessment, and then providing privacy. Again, that's review from your nursing assistant program. We also always want to provide privacy. We've talked about HIPAA. So those concepts are transfer to this concept as well. You want to consider your seating arrangement. We talked about in communication about space, personal space and distance, having good eye contact. Again, all of these methods, themes transcend through to help you collect your data. Now, the methods of collecting data can be, again, through physical examination, auscultation, using your stethoscope, getting vital signs, many methods of getting information. So the many methods of getting information. The framework at MATC for for doing a physical assessment or gathering data is, of course, Gordon's functional health patterns, and we're going to do a lot with that more on Tuesday, so make sure you bring your notebooks. There are other models. These are of nursing assessment. Key, all I really want you to know here is that when you are taking care of people or assessing them, you have to prioritize their needs. So if a patient is starving and they can't eat, they're going to give you much more information if we can get them a meal or they know a meal is coming. If that's a higher functioning order need. If they're in a lot of pain, the pain becomes the higher need for the patient versus talking to you. So give them something for pain, get them comfortable, and come back and try to reassess them. So key here is just organizing, prioritizing what you should do and when you are going to do it. And again, learning that process of organizing and prioritizing you'll build over time. It will come more as we practice. And we want to validate the data. Once your assessment is complete, you want to make sure that what you have documented or that you're going to document is correct. And you don't want to jump to conclusions. You don't want to say, oh, because the patient says he has pain, they're having a heart attack. You want to validate what the pain, how the patient rates the pain, where the pain is, how long did it last, is it radiating, do they have any of the other signs of a heart attack? So you want to validate. You don't want to jump to conclusions. You want to always get as much information as you can. And then you want to document. Once you have collected the information, you want to document it. So again, this section is on assessment. Key factors in this lecture is in this section is to understand that you're collecting data, you're organizing, you're validating, and you're checking it. You want to remember that there are two kinds of data. There are key is that you're collecting subjective data and objective data, and that your subjective data you're collecting, and you're also collecting objective data. And then you want to remember that what are your sources of information? Is it primary or secondary? Those are really key components. Knowing that what kind of data you're collecting, objective or subjective, is it primary or secondary? Are you using records, x-rays, CT scans, patient history? And that you're integrating skills from from the last unit, your communication skills regarding interviewing and using open-ended questions versus closed-ended questions to help you gather data and have a good assessment. So that's what I want to go over for you guys for Tuesday. Please think about any questions. Review this. If you have any, make sure you make a list of questions. We're going to begin our next class period, doing activities in which we're going to apply this information. I look forward to seeing you and make it a great day.